Yeah, good morning, friends, and thank you, Dr. Devan, for including me in this course. Now, already he told you my opening sentence that OCT machine, probably OCT machine in relation to glaucoma is the most abused machine in ophthalmology. But the same principle holds true what just now Dr. Pandav told you, that perimetry, any defect you get it only in isolation you cannot diagnose. You have to correlate clinically. That holds more true with glaucoma, with OCT. Okay. Now, OCT will tell you it serves two purposes. One is at any stage, what is the stage of the disease, it can diagnose certain things, and what is the progress. So, probably the progression is the most important aspect of OCT machine, various layers, which is all those standard things. But in glaucoma, what is done, evaluated is the RNFL thickness along the optic disc, the optic nerve head analysis, and macular thickness. And these days, ganglion cell complex has fancy names have come. But I don't give any importance to these two things, only take give importance to the RNFL. Now, even these are the various evolution in the OCT, the time domain, then spectral domain, swept source OCT, and because of swept source, the tissue demarcation is really, it has become very more accurate, very accurate. Now, just quickly to save time, this is the usual printout of a OCT machine. Now, in this, I'll not go into detail, but mainly what you are seeing, as I told you, RNFL thickness along the optic disc. So that is how it is presented in this printout. This is the actually thickness map. So actual thickness map based on the color, and the color coding is given at the scale is given at the site. So the blue color means it's a thinner area, and the red or the yellow is darker area. So in the upper and lower, this is the normal appearance of the CT of the OCT. Okay. Now, this one is the deviation map, means from the normative database, whatever is the deviation in this particular patient, so that will give you over here, and this gives you not in the micron, this gives you in the significance, p-value. So at all p-value based on the color, whether it is yellow means borderline, red means it's definitely significantly deviated from the normative database. So you have to concentrate at the upper and lower part in glaucoma, not anywhere else, not on the nasal, not on the temporal. Then, so this one is about the disc evaluation, which I don't give any importance. Now, these are the various stereometric parameters. Fortunately, all these parameters are color coded based on the p-value. So if something is significant, you will see that in red. But beware, don't just simply go by the color. That's why it's, some people also call it a red disease, because actually there is no glaucoma. All things are red in this recording and in this presentation. So you think, oh, it's a very advanced stage of glaucoma. So that you have to be careful about it. Now, this is the RNFL curve which is given. The RNFL thickness curve, this one. And this one is the quadrant-wise measurement of the retinal nerve fiber layer thickness. So basically concentrate not on this, concentrate more on this clock hour wise, because that gives you very localized location, means you are reading, especially in the upper and the lower, mainly upper temporal, lower temporal, that is more important for glaucoma. So that abnormal, whether it's a red color or the yellow or green, so those things you have to see. Also, so this is just the what abnormality you will see. Whether it is glaucoma or not, you have to correlate clinically. You have to take the patient in the entirety. Now, this one is follow-up examination in that. So, follow-up examination, basically after the third examination onwards, it will start giving you the deviation. Means what is the variation from the baseline, where the first two fields are taken as baseline, and mean of that, from that it is compared. And then you get the various curves of the superior, inferior, or the entire RNFL thickness, or CD ratio. So, these four curves you are getting. Now, these three are the nerve fiber, superior, inferior, and entire. So if it is going down, means it is progressing. And this one is the CD ratio. So if it is going up, means this is progressing, where the CD ratio is increasing. But beware that whatever is the progression, you have to see that the machine, how sensitive the machine is, because the retest variability you have to take into consideration. Because if you say you are getting 6 micron difference, and 6 difference is the just retest variability, then actually you are not sure whether it's because of this or actually because of progression. So any progression, if it is constant, continuously going, you also get some parameters. So that you have to study minutely. Now, GCC complex, basically I don't give any importance so far, because different machines takes into consideration different layers in this calculation, plus there is a lot of confounding factors. age-related macular degeneration, diabetes, macular edema, anything, macular degeneration. So a lot of, even the vitreous traction because of the PVD, all those things can change the thickness. So there is a lot of confounders. So those limitation you keep in mind. Now just come to this. In the posterior imaging, whatever you are doing with OCT, it can serve two purposes. One is initial diagnosis, other is follow-up to judge the progression. According to me, this is the most important use of OCT machine, especially in pre-perimetric stage of glaucoma, when they actually the other things are not very apparent. Okay, and this is based on this 40% nerve fibers before the field defect appears, but this can show you other. That because of this, pre-perimetric glaucoma term has been coined. There is no standard deviation of pre-perimetric glaucoma. Disc retinal nerve fibers are definitely suggestive of glaucoma on examination. Normal fields on SAP, short wave or normal field on the standard automated perimetry. And intraocular pressure may be normal, in the normal range, or may be high. Now limitations, all these machines, whatever the advancement has taken place, it has got all the sensitivity and specificity between 70% and 90%. In established glaucoma, we are talking about pre-perimetric glaucoma. So again, whether it can be extrapolated to this or not is a question mark. An enough Indian normative database is not available. Now this one is really something which gives you some thought process. I want to provoke your thinking process, because in LVP, there are three, basically earlier there were three machines, imaging modalities, OCT, HRT and GDX. Now established glaucoma patients, all patients, 70 glaucomatous and 94 normals. So 70 glaucomatous patients where the perimetric defects were there. They were subjected to all three tests. Then what do we expect? If it can diagnose glaucoma before the perimetric defect, all 70 would have shown positive on all three machines. But this was not the case. Only limited number showed 15 when all machines abnormal, but some of them didn't show on any machine, some of them on one machine, some of them on two machines. So this will also probably give you what are the limitations. So now what are the points to ponder? The EMGT, CNTGS and OAT study, these are some studies, different stages of glaucoma, where there were two arms treated. One was treated arm, other was no treatment given. So all patients, but then what are the main findings? All patients in treated arm did not show non-progression, because treated arm should not show any progression, but some of them did progress. All patients in control arm, all did not progress. All should have progressed, but all did not progress. So these indicate towards some other factors responsible for progression as well. This is simple, which probably right now we don't know. So, but what is the implication of that statement which I told you just now? Not all need treatment with present modality, because if something we know that, okay, we can control some vascular thing or we can control some different theories which we are talking about, then of course we can treat, but all patients with present modalities, not all need treatment. We are extrapolating treatment effect on established glaucoma patients to pre-perimetric glaucoma. So there has been no study about effect on treatment on pre-perimetric glaucoma, all on established glaucoma. And plus, still we want to label a patient with pre-perimetric glaucoma and start treatment. But here, now be careful that what is the take-home message, final slide. In perimetric glaucoma, so before that I'll tell you, then you will definitely ask me, sir, when a patient of glaucoma comes and the pre-perimetric glaucoma, suspect, perimetry normal, pressure disc is suspicious, and this is showing, then what will you do? I will do this test. If it is showing abnormal, if it is normal, I am very happy, but I will follow up. If it is showing abnormal, then still I will not start treatment. What I do, probably now I have got a better tool to follow up, so I will do it more frequently, this test. And if it is showing progression on that maybe in 1 year, because it's not a malignant disease, it will not, patient will go blind in 1 year or 2 years. So if it is showing progression, probably I am correct in starting treatment. But it means that, do I start sometime treatment only on first time on this abnormality? Yes, sometimes. If the patient belongs to a very high risk group, like patient has got some risk factors, a strong family history of glaucoma, someone in the family has really lost eyesight definitely because of glaucoma. So those things, pressure is high, then it's very high, then those situations definitely I'll start even on the first time, but otherwise not. So basically in this, and sometimes, so in perimetric glaucoma, these tests are unnecessary burden to the patient. Then definitely you will ask, sir, do you ever do in established glaucoma patient this test? I will say, you should not do, because first statement says that, but still I do it. Why I do it? Just to safeguard me, that suppose I am treating for 5 years, patient goes to somewhere else and they says, "Arey, you have glaucoma, OCT has not been done." And he is treating glaucoma. He calls himself glaucoma expert, not done it. Just to safeguard this statement, I do it, but not that frequently. I'll repeat it after 2 years, after 3 years, but at least I'll do it. The diagnostic ability of newer devices of pre-PG is limited and questionable. These devices can be used to confirm progression over time to so-called PPG. This is probably the best use of this machine. Initiating treatment on the diagnosis of PPG on single examination should also be questionable, as explained, and judicious application of these devices with limitations in mind can improve glaucoma management in pre-perimetric glaucoma. So I think in the limited time, I have just put my point forward that how to use this OCT machine.